Well, welcome everybody. We've still got people joining. I'm not quite sure, but I think we thought we may have as many as 200 people joining this call, which would be a fantastic demonstration of interest in this really important topic. My name's Peter Spielsberg. I'm Director of the Strategy Unit. We're an NHS team that works across our local area, but also regionally and nationally to try to improve the application of evidence and analytical insight into making the best possible decisions about how to improve health and care and well-being. There's a lot more we could say about the Decision Support Network, but as it happens, if you go to the next slide, Stephen, we presented a mini huddle yesterday on NHS Futures to describe the arrangements and all the various components of the network and how it operates and what the Decision Support Centre brings to it in terms of the education programmes, as well as the sorts of things we're talking about today. So the easiest way for you to be able to find out about that is to go to the link there, because it's now been, the recording of it has now been posted on the NHS Futures site. So at that point, we can concentrate for the rest of today on this particular project. And I'm really pleased that we've got Stephen Wyatt here to present it. Stephen is the Chief Analyst for the Midlands Decision Support Network. He's also leads the analytical function in the strategy unit. And it's great to have you here, Stephen, to present this important project. Thank you.
Thanks, Peter. I'm going to start by telling you something you probably already know or suspected. This chart shows the rates of admission to hospital in an emergency on the left and in a planned fashion on the right for the population of England in 2018. And each chart's got 10 dots on it, and each of the dots represents 10% of the population. The dots furthest to the left of each chart represents the experiences of people living in the most deprived populations of England. Deprivation measured by access to education or housing or employment and levels of crime, etc. And the dots furthest to the right represent the 10% of the population with the lowest levels of deprivation. So really, as a shorthand, we can think of the dots on the left of these charts representing the experiences of our poorest populations, and the dots on the right representing the experiences of our wealthiest populations. And what the charts show is that people living in the most deprived areas, our poorest populations, have much higher rates of access to hospital in an emergency compared to their more affluent counterparts, but lower levels of access in a planned fashion. As I say, I suspect most people who work in the health service already understand that dynamic is at play. And this is not a new piece of analysis. Other people have demonstrated this to be the case in the past. But I think there are a few follow-up questions where there is greater uncertainty. For example, are the differences that we see clinically justified? Might it be that people living in more deprived areas, the reason why they have lower rates of access in a planned fashion is because they have lower levels of need? Tackling health inequalities has been a long-standing NHS policy objective. We've been trying to address this issue for some time. But have we been successful, at least in respect to planned care? Are the levels of inequality increasing or decreasing over time? Next, where along the pathway, the patient pathway, do these inequalities start to emerge? When somebody receives a planned admission to hospital for some surgery or a diagnostic test, for example, there are a series of earlier steps which must take place. The doctor needs to recognise they have a particular condition, and need to treat them in primary care, refer them on to secondary care. A consultant within the secondary care setting needs to decide whether or not treatment is required. So where along that process do the inequalities that we see start to emerge? And finally, does the poorer access we see to planned hospital care for those living in the more deprived communities, does that serve to increase demand for unplanned care? Now, I suspect there's a degree of uncertainty in our minds about these various questions. And our view was that a piece of analysis on these topics might help reduce the decision makers' uncertainty and therefore support decision makers to take more proactive steps to address the problems that we see. So I'm going to come back to this slide at the end and ask you the question again, has the analysis that we performed reduced your uncertainty in these areas? Has it supported you maybe to take some more immediate actions to address the problems that we see? Before I move off the slide, I might just ask you to think what your prior beliefs or knowledge is in these areas. What do you think is the case for each of these 4 questions? So that as I move through the analysis, you can check whether or not the analysis that we're providing is either confirming your prior beliefs or challenging your prior beliefs. So I'm going to start with a few slides just to orientate us a little bit to understand the territory that we're going to be exploring. This chart shows the rates of elective spells and outpatient attendances over time from 2005 through to 2018. So in 2018, the NHS was delivering about 150 elective spells and 1,700 outpatient appointments for every 1,000 people in the population. So these are really significant areas of activity for the NHS. Considerable quantities of effort are expended delivering this activity and resources. And we've seen really rapid increases in the levels of these types of activity, much higher than in most other forms of NHS activity over the same period. And maybe one of the questions we need to ask was, if we put ourselves back in 2005, and we were going to increase elective activity by this amount, where would we want to focus that increased activity? Who would we want it to be focused on? And what sort of activity would we want that to be doing? There's another question, which is that would we want to increase elective spells or outpatient attendances by this quantity? Would we have chosen, if we had the choice, to use that money elsewhere within the health system? This chart here shows the age-sex profile for elective spells in blue and outpatient attendances in yellow. And as you'd expect, rates of activity increase fairly steadily as people get older, and then they tail off roughly after the age of 80 as the balance between risks and benefits changes as people get particularly old. The dot that's out of step at age 55, that represents the activity associated with the bowel scope screening programme, which was discontinued earlier this year. This chart shows which conditions most of the elective activity is focused on addressing. So the condition that consumes the greatest proportion of activity is cancers, followed by digestive system disorders, musculoskeletal disorders, and eye conditions. The dark blue dot shows the position in 2018, and the lighter blue dot shows the position in 2005. So you can see really quite considerable levels of growth in digestive system disorders, but actually reductions in activity for circulatory disorders as the prevalence of those conditions is falling. This chart again explores this issue about differences in access to planned hospital care, elective spells on the left and outpatient attendances on the right, by deciles of deprivation, with the most deprived people on the left of the chart and the least deprived populations on the right of the chart. The darker dots show the position in 2018. There are higher rates of elective spells in the least deprived populations in 2018. Roughly equal levels of outpatient attendances across all deprivation deciles in 2018. The lighter dots show the position in 2005. So for elective spells, we see the opposite gradient. In 2005, we saw higher levels of activity for people in the most deprived populations. And by 2018, that pattern had reversed. The way to look at this is to explore the growth rates in elective spells and outpatient attendances by deprivation decile. And in this chart, we've adjusted for changes in the age-sex structure of each population within deprivation deciles. And what the charts show is that we see much higher levels of growth in both elective spells and outpatient attendances between 2005 and 2018 in the least deprived populations. So although we've seen increases in elective spells and outpatient attendances for all populations, those rates of growth are much more rapid in the least deprived populations. And we also see a skew towards higher rates of activity in the least deprived populations for most of the main forms of disease that generate activity, planned care activity. The skew is particularly marked for cancers, conditions of the eye and circulatory disorders, and maybe less marked for things like nervous system disorders and skin conditions. And there are a small number of conditions where the skew is in the opposite direction, where higher rates of elective care are seen in the more deprived populations. But generally speaking, they contribute fairly limited levels of activity and demand for planned care. And we also see the same skew in favour of people living in the least deprived areas within each STP, within the Midlands region. The only possible exception to that is Lincolnshire, where we don't really see any evidence of any difference in rates of both elective scars and outpatient attendance in Lincolnshire. But for most other STPs in the region, there is some skew towards people living in the least deprived populations. So the next question I wanted to ask was about where along the pathway do these inequities start to emerge? And furthermore, are the inequalities that we see, are they clinically justified? So our approach here was to consider 4 pathways. These are all sort of fairly high volume pathways that lead to secondary care activity. For chronic obstructive pulmonary disease, COPD, for heart failure, hip arthritis and cataracts. The first 2 are predominantly medical pathways, and the second 2 are predominantly surgical pathways. And we've looked at levels of activity across those 4 pathways for each of the deciles of deprivation. And rather than just calculate rates per head of population, we're actually looking at rates per unit of individual for every individual with that condition. So we're adjusting for levels of need, not just for the size of the population here. So any differences we see can't be explained by differences in need. We've adjusted for levels of need in this analysis. So we've picked various measures of activity along the care pathway. And we've got 6 stages in the care pathway that we consider. First of all, identification of the disease in primary care, moving on to management of the condition within primary care, prescribing within primary care, a referral on to secondary care, the management of the condition within secondary care, and finally treatment of the condition within secondary care. And so for each of the 4 pathways, we've got measures of activity along those 6 stages of the care pathway. And I'm going to show you how rates of inequality vary as we move through the pathway. So first of all, let's look at the COPD pathway. These are the first 3 stages of the COPD pathway. We start with identification first of all, and our measure of activity here is whether or not somebody is placed on the COPD register. And so we're looking at the numbers of people on the COPD register relative to the number of people with COPD in that population. And we move from the most deprived areas on the left of the chart to the least deprived areas on the right of the chart. And the chart's indicating that people in the most deprived areas are more likely to be placed on the COPD register if they have COPD than people in the least deprived areas. As we move down to the next stage of the pathway, primary care management, we see that people are also in the more deprived areas, more likely to receive an annual review and slightly more likely to receive a flu vaccination. Moving on to the third stage of the pathway, we see that people are more likely to be prescribed bronchodilators and steroid inhalers. On to the 4th level of the pathway, we see referrals into secondary care. Patients in the more deprived areas are more likely, patients with COPD in the more deprived areas are more likely to be referred onto secondary care and to be offered pulmonary rehab, and marginally more likely to attend a first outpatient attendance in secondary care. So at this point, all the way through the pathway, the skew has been towards people living in the most deprived areas with higher rates of activity relative to need in the most deprived areas. But at the end of the pathway, secondary care treatment, at the very end of the pathway, we see the gradient reverse, and people living in the least deprived areas now are getting greater access to lung volume reduction surgery with the steroid tablets. And we can sort of bring all of that information together into a single chart that looks like this. Again, we're moving through the pathway from the top identification through to secondary care treatments at the end of the pathway. A point to the left of the chart indicates that activity after adjusting for need is in favour of people living in the most deprived areas. A point towards the right in blue suggests that activity is in favour of people living in the least deprived areas. What we see is that as we move through the pathway, people start off in the earlier parts of the pathway, the skew is in favour of people living in the most deprived areas. But by the time we get to the end of the pathway, the skew is in favour of people living in the least deprived areas. And that switch only happens really very late in the pathway process. We can show you the equivalent charts now for heart failure, where we see a very similar picture. Earlier parts of the heart failure pathway, the skews are in favour of people living in the most deprived areas. But only at the very end of the pathway do we see the skew reverse in favour of people living in the least deprived areas. A little bit less clear for hip arthritis, but broadly a very similar pattern. Higher rates of activity in favour of the most deprived areas, earlier parts of the pathway. By the time we get to secondary care treatments, the skew reverses in favour of people living in the least deprived areas. And possibly the least useful of the charts is the one for cataracts. We really struggle to find activity that we could measure at the earlier parts of the pathway. And there's great uncertainty really about the activity rates for the later parts of the pathway. Bringing all those four pathways together, I think you'd agree the general pattern is that in earlier parts of the pathway, activities favour those people living in the most deprived areas. But by the time we get to the end of the pathway where secondary care treatments occur, the skew reverses in favour of people living in the least deprived areas. So there's a question about really why we're seeing the patterns that we're observing. There are two key factors I think that we're seeing. One is that in more recent years, the activity has favoured people living in the least deprived areas. The growth in elective activity and outpatient counts has been greater for people living in the least deprived areas. And the second pattern that we want to try and understand is why we see those changes only very late in the pathway. And I'm going to offer you just a few slides now which might give some insight into why we're seeing those patterns. So this chart shows the percentage of patients that receive their elective admission with an NHS-funded elective admission within the independent sector. So early in the 2000s, a series of independent sector treatment centres were established, and there was a policy known as the extended choice policy, which meant that individuals who were being referred for secondary care treatment could choose to receive their care in a limited set of independent sector providers. And what the chart shows is that over time, from the early 2000s through to the late 2010s, rates of access to NHS-funded treatment in the independent sector has increased generally. So the policy of moving some activity towards the independent sector has been successful. And on average, about 7% of all elective activity now seems to be delivered by the independent sector. But we also see a differential opening up between those people living in the most deprived areas, shown as the red dots, and the least deprived areas, shown as the yellow dots. And really, by the time we get to sort of 2010 or 11, we can see really quite big differences in the rates of access to NHS-funded treatment in the independent sector between deciles of deprivation. The people living in the most deprived areas much less likely to receive their treatment in the private sector, NHS-funded treatment in the private sector, than people living in the least deprived areas. The other big policy initiative was to reduce waiting times for elective care. And there's been a range of policy initiatives to address that, and a range of metrics that have been used to measure progress on that policy. This metric that we're using here is one of the old metrics. I'm using it because we can get consistent data right for the full period that we're interested in. And the metric is whether people receive the treatment they need within 12 weeks of a decision to admit the patient. And we see that, generally speaking, and the pattern is that waiting times improved dramatically in the late parts of the 2000s. and since then have tailed off somewhat. But the other pattern is to see that in the early parts of this diagram, people living in the most deprived areas receive faster access to care than people living in the least deprived areas. The blue dots above the yellow dots in the early part of the chart. By the time you get to 2014, that pattern has reversed, and people living in the least deprived areas are now getting faster care, faster access to elective care than people living in the most deprived areas. Since then, the pattern has become less clear. We've also seen lots of new surgical techniques and diagnostic techniques introduced over the last 10 or 15 years. These charts show what's happened to growth rates in two particular forms of diagnostic procedure. Colonographies, which is essentially a CT scan of the colon and often replaces a colonoscopy, more invasive colonoscopy. And SPECT, which is a scanning technique that often replaces PET scans, which are also possible but more expensive. So these are new techniques, new diagnostic techniques that have been rolled out across the NHS over the last 20 years or so. We've seen higher rates of growth in access to those treatments in people living in the least deprived areas. There's lots of procedures then which we've tried to cut back on over the last 15 or 20 years. Procedures where we would think there is limited evidence of clinical gain, and there's concern that maybe we're supplying some forms of surgery in too high numbers, and lots of patients who receive those forms of surgery weren't getting any benefit. And so we've reduced, for example, the number of people receiving carpal tunnel release surgery, but also the numbers of people who receive a tonsillectomy surgery. But the rates of decrease in those forms of surgery are greater for people living in the most deprived areas. So when we decide to cut back on treatment in the NHS, we seem to target people living in the most deprived areas more strongly. And finally, I just want to show what's happened with a couple of screening programs that were introduced in the NHS over the last 10 or 20 years. These are the screening programs for AAA and for bowel cancer. And there are elective activity which follows on from those screening programs. And generally speaking, we see higher rates of growth in those forms of activity for people living in the least deprived areas. Taken together, I want us to expose our emerging theories that the various policy initiatives that have been introduced over the last 15 or 20 years to increase or improve access to planned care, so there might be waiting times targets, choice initiatives, NHS funded access to the private sector, and new treatments and screening programs. Or to control access to elective care, these are policies or procedures of limited clinical value, lifestyle-based eligibility criteria for surgery, and referral management services. But our emerging theory is that although those programs may have been successful in their own right, reducing waiting times, increasing choice, etc., they may have had a differential impact on those people living in the most deprived areas. The last area we wanted to look at was this issue about the relationship between planned care, planned hospital care, and unplanned hospital care, and whether there was a relationship between the two. This is the slide I started with. The question really is whether the slope, the blue slope that we see, differential rates of access to planned hospital care, might at least in part explain the red slope on the left-hand side. The reason why we're seeing higher rates of emergency spells in the most deprived populations is that because they have poorer rates of access to elective spells. So there's lots of good anecdotal evidence to support a causal relationship here. We obviously see that inverse relationship I've just shown you. We also see that we've seen larger increases in elective care in the least deprived populations over the last few years, and slower increases in emergency spells in those populations. If you look at rates of emergency spells prior to an elective admission and then after an elective admission, you see them rise steadily before an elective spell and decline steadily afterwards. So any poor access to elective spells it's not unreasonable to suspect that might precipitate higher rates of elective spells as a consequence. And we also see higher rates of prior emergency spells and readmissions following elective spells of people living in the most deprived areas. So lots of good anecdotal reasons to suspect there might be a causal relationship there. We wanted to test that relationship a little bit more formally, and we used a particular statistical or economic technique to address that question. I'm not here going into the detail of the methods, but I'll take you through the results. So the models that we built suggested that there is indeed a relationship between these two quantities, and that increases in elective spells, all other things being equal, lead to reductions in emergency spells. We estimate that effect accumulates over a 2-year period. So most of the effect is felt within the first 6 months, but there continues to be benefits, reduced levels of emergency admissions over a 2-year period after you increase the levels of elective spells within the population. And our estimate is that for every 10 additional elective spells, roughly 1 emergency spell is avoided. There is also a relationship between emergency spells and outpatient attendances, but that effect is very small and uncertain. We suggest that's largely, you'd be reasonable to ignore that relationship. Focus really on the relationship between elective spells and emergency spells. To show you what might happen if let's imagine we were able to level up access to elective spells across quintiles of deprivation, so that we gave the same levels of access to people living in the most deprived areas as the people living in the least deprived areas within each STP. So the chart on the left shows the rates of elective spells across quintiles of deprivation. That's the chart we've seen before. And I want you to consider what might happen if we manage to increase levels of activity in the most deprived populations. That would take something like a 10% increase overall in elective activity. So very difficult to achieve, very expensive to achieve, particularly now when we're struggling to deal with current waiting lists. But nonetheless, it's a useful thought experiment. There are other ways of equaling up care. You could, for example, level down, bring down the rates of elective care in the most affluent populations down to the levels in the most deprived populations. Or you could go for a redistribution approach where you take all the activity, don't attempt to increase the level of activity, but to share it out more evenly, more fairly across populations. We estimate the effect, if we were to do that, nonetheless, the levelling up strategy of this modest reduction in emergency spells. So roughly a 10% increase in elective spells would lead to a 1.3% reduction in emergency spells. That's not going to give you a return on investment. Emergency spells are marginally more expensive on average than elective spells, but probably only 25 or 30% more expensive per unit of activity. But they do consume many more bed days, something like 7 times the number of bed days for each emergency spell as for each elective spell. And of course, if we can reduce the number of emergency spells, then we'll also take out A&E attendances. And these will be complex A&E attendances that result in admission. And that itself would have a great benefit to our emergency departments, which are very much under pressure. So there are lots of good reasons for considering a strategy to level out access to elective spells. And if we were to do that across all STPs, the impact we'd see would be slightly different. In areas like Lincolnshire, where the levels of inequalities are much less marked, we'd see smaller reductions in emergency spells. In places like the Black Country and West Birmingham, where there are significant inequalities in access to elective spells, we'd see big reductions in rates of emergency spells there, maybe 4% reduction. So that's the analysis we wanted to share with you. I'm going to come back to the 4 questions I asked at the start and ask you to reflect on whether or not the analysis that we provided has been able to, at least to some extent, reduce your uncertainty about these questions. I think expecting perfect knowledge in areas as complex as these is probably not realistic, but it's certainly feasible, I think, for a piece of analysis of this type to have an ambition. It's reasonable for it to have ambition to reduce levels of uncertainty on these sorts of questions. And the reason we want to reduce your uncertainty is because we hope that that will lead to greater decision confidence and greater ability to act to address these problems. I want to leave you with just a couple of other questions. So in your local areas, how confident are you that local planned care policies that you have, policies relating to choice or procedures of limited clinical value, referral management arrangements, waiting list prioritisation arrangements, access to aftercare, for example, how confident are you that those policies don't unintentionally disadvantage people living in more deprived areas? And secondly, how confident are you that there isn't any unconscious bias taking place in the decision-making process between a patient and a clinician when they're seeking to decide whether or not to go ahead with surgery, and where they're trying to balance up the benefits and risks of treatments and secondary care? So there's a few things that we can offer from here. There's a formal report that's available on our website now. There's a link there which is available to you. For each of the Midlands STPs and ICSs, there's a separate pathway level analysis, the analysis of the 4 pathways showing levels of inequality through those pathways for each STP and ICS. There's also a series of R markdown files, more targeted at our analyst colleagues within STPs and ICSs who want to see the process that we followed, the data sets that we used, how we managed the data, and how we conducted our analysis, so that you can check and replicate and take forward the analysis that we've carried out. Those are available on our GitHub website, and there's a link within the report to that website. We'd also be happy to facilitate action planning sessions for your boards or for your board subgroups to help you think through what actions you might take to address some of these inequalities, given the information presented in our report and your local knowledge. And the last thing I wanted to mention was that there's in the next set of analytical projects that we'll be carrying out, that the DSU strategic group have prioritised us to address. One of those projects is going to be looking at assessments of strategies to reduce inequalities in access to primary hospital care. What are the various strategies that local areas might adopt, and how might they compare? And our colleague Rachel Caswell is leading that particular piece of work. I'm going to finish there and hand back maybe to colleagues if anybody has any questions they want to ask of us. We can either pick those up in the chat, or if you want to call out, we can try and address any questions that you might have about the